Hi, everyone, and happy Purple Day, and welcome to Pammy's webinar on Knowing Matters, How SUDEP Awareness Shapes Parental Grief, Trauma, and Coping, where we'll explore how prior awareness of SUDEP profoundly influences trauma, grief, guilt, and coping after loss. We'll discuss parents' lived experiences, the consequences of silence, and why proactive, compassionate SUDEP counseling is essential for families and clinicians alike. Thank you for joining us this afternoon or evening, morning, wherever it may be for you. I'm Allison Kukla, the Senior Advisor for PAMI, and I'll be your moderator this afternoon. We love to see where everyone's joining us from, so please share that in the chat. I'm in sunny Chicago today, but it's going to be back to 30 degrees winter tomorrow. And if you're new to PAMI, please let us know. We love to see if we have new faces in the audience. Just a few housekeeping items before we get started. We want your questions, so please put them in the chat or the Q&A box so I can track them and ask our panelists the questions during the Q&A time, or they might answer them themselves during the webinar. I do like to remind everyone we can't give specific medical advice, so please keep your questions as general in nature and to the topics that are being presented. If you do have specific medical advice, always take those to your healthcare team. We also encourage connection here at PAMI. So if you can use, you can use the chat to connect with others. And lastly, we're recording today's webinar, and it'll be available within 24 hours on our YouTube channel, and we'll send out an email once it's available. We do have a sponsor for today's webinar, and PAMI would like to thank Neurelis, who is generously supporting today's webinar. We'd like to thank them very much for not just today's support, but their continued support for PAMI's work that we do. And we are grateful for our speakers who are with us, who might not like to see their faces on this slide, but we couldn't do this webinar without them. So thank you for joining us today on this very important topic. During this webinar, as I was saying, you'll hear about a recent qualitative study of parents who lost a child to SUDEP. The study explores how prior awareness of SUDEP profoundly influences trauma, grief, and guilt in coping after loss. We'll discuss parents' lived experiences, the consequences of silence, and why proactive, compassionate SUDEP counseling is essential for families and clinicians alike. I'll do brief introductions of everyone, and then I'll stop talking and turn it over to them why you're really here today. So Jennifer Sime lost her 19-year-old son, Brendan, to SUDEP in 2017. She is the current co-chair of the Epilepsy Foundation of Iowa Community Outreach and Engagement Board and has been the SUDEP ambassador for Iowa since 2019. She has served on the Dana-Dwek Foundation Board of Directors since 2021 and is currently the board vice president. Jennifer has participated in various educational and professional conferences and webinars, sharing her personal story and advocating for SUDEP and epilepsy awareness. She's a registered nurse for over 30 years and has two grown daughters, Josie and Maya, and lives in Iowa with her husband, Todd, and youngest daughter, Ivy. We're excited to have Jennifer with us today. We have Dr. Itay, who is a pediatric neurologist and epileptologist specializing in epilepsy and inherited metabolic epilepsies. He is currently an attending physician in pediatric neurology and epilepsy and the director of the Neurostimulation service at Dana-Dwek Children's Hospital and Tel Aviv Medical Center. Dr. Itay completed fellowships in epilepsy and metabolic epilepsies at Boston Children's Hospital and Harvard Medical School. One of his research areas, there are many, is SUDEP, with particular emphasis on family experience, counseling, and prevention strategies. His work bridges clinical care, translational research, and medical education with a strong commitment to improving outcomes and communication for children with epilepsy and their families. And then last but not least, we have Dr. Phil with us as well. He is the Director of Epilepsy and Clinical Neurophysiology at Boston Children's Hospital and William G. Lennox Chair and Professor of Neurology at Harvard Medical School. He attended Johns Hopkins University and the Peabody Conservatory of Music and the University of Maryland School of Medicine. His major research interest is inherited metabolic epilepsies. Dr. Pearl is a member of the Music and Health Institute at the Berklee College of Music in Boston, board member of the International Children Neurology Association, and past president of the Professors of Child Neurology and Child Neurology Society. So as you can see, a mouthful of all of those wonderful introductions. And I am thrilled to have all of these wonderful friends and colleagues here with us today to present. So we'll first hear from Jennifer, followed by Dr. Itay and Dr. Phil, and then Dr. Itay, we'll go back to him to wrap us up. So keep those questions coming in the chat. We'll keep monitoring them throughout the presentations, and then we'll ask them to our speakers at the end of the presentation. So with that, Jennifer, I will.
All right. Thank you, Allison. So first of all, I just community space for everyone. Just find share your loved ones' names in the comments so that we can hold them in our thoughts time together. This is my son, Brendan. He was born August 1998. He made me a mom for the first time. He was my only son. Brendan was a quiet, caring, and working kid. He was loved and respected by his friends and teachers, coaches, and he was a reliable but quiet. Growing up, he was a typical big brother to his oldest sister, Josie and Maya, who were many times the recipients of his practical joke, had a special bond with. Next slide. November of 2008, at the age of 10, Brendan started having absent seizures. His fourth grade teacher noticed he was having staring spells in class, and she knew these were seizures because her adult daughter had epilepsy. 3 months later, Brendan had his first tonic-clonic seizure while sleeping. With a normal brain MRI and a visit to our PCP, he started his first medication, only to have significant side effects, and all while his seizures were increasing. He went multiple weeks in a row having tonic-clonic seizures every night while he slept. After 6 months of medication, changes, multiple EEGs, and initial neuro consultation, Brendan gained control of his seizures. And for the next 3.5 years, he lived seizure-free, 13 months of that off of any medication. Next slide. At the age of 14, following a sleepover at a friend's house, Brendan had his next seizure and was put back on medication. Over the next 4.5 years, he would have 3 more breakthrough seizures, all tonic-clonic, while sleeping. Then on November 28th, 2017, while asleep in his college dorm room, he died of SUDEP. This was just his 5th seizure in the span of 8 years. Brendan lived with epilepsy for 9 years. He saw multiple teams of providers at 3 different clinics, from primary care to pediatric neurology PA, MDs, and to his final provider, a pediatric epileptologist. Not once did any of them mention SUDEP, and even with the risk factors he had. 2 weeks before leaving for college, Brendan had a breakthrough seizure. At a routine neurology appointment the following week, he was told it was probably a fluke and no change in treatment was needed. We discussed Brendan's transition to college, the increased stresses it would bring, and increased self-care that would be needed. We obtained a letter of accommodation in case he would have a seizure and need to miss class, or if there were situations where he'd be involved in activities at heights or in water. We transferred his medication to the university pharmacy, and although he had never needed it, we asked about having a rescue medication. His provider felt this was too much responsibility for his roommate and was not necessary. He offered Brendan a one-time daily dose option of his medication versus the twice daily dose he was on. However, Brendan had a great routine and compliance with his current medication schedule, so he did not wish to change any of that. We left the appointment feeling like we had everything covered and that Brendan was set up to thrive and succeed. The goal was to be seizure-free so he could come off his medication. It was never to be seizure-free to save his life. 105 days after moving down to college, his roommate found Brendan in his bed unresponsive. He attempted CPR, but Brendan was already gone. 2 police officers came to our home but did not know any of the details and handed us a piece of paper with the investigator's name and number. And then the most difficult conversations that would bring life-changing pain to so many, starting with the sisters who were 16, 14, and 4 years old at that time. The hardest thing I've ever had to do. How would I protect them from the hurt and trauma? How would I help them through this? So many heartbreaking conversations and no understanding of what happened to our healthy, vibrant, full of life Brendan. An overwhelming feeling of holding and caring for so many broken hearts while my heart sighed. We went to pack up his dorm room. The friends that he made over the 105 days at college greeted us with hugs and tears, followed by stories and laughter about the wonderful friend he was and the wonderful life he was creating in college. It was then that one of his friends asked if Brendan died of SUDEP. All I could say is, I have no idea. My 3.5 hour car ride home left me with so many questions and only Google to provide any answers. Next slide. I pulled two words and one phrase that were part of this study, and I've added my thoughts and feelings. I would love for you to comment and tell me what your thoughts and feelings when you hear these: trauma, guilt, long-term coping. As you can see, a lot of us have in common that it's sudden, unexpected with the death of SUDEP. It's shock, devastation, isolation, anger. Um, Oftentimes people ask me how I work on coping and long-term coping. Next slide. And when I think of my advocacy work, I have three concepts that help set my intentions, and they'll be on these next three slides. And this is what helps guide me. It's grief and action, connection and community, love and advocacy. It took me a year or so to really start to get my feet on the ground with advocacy, starting with our first walk 6 months after Brendan died. Connecting with Roxanne, the executive director at the Epilepsy Foundation of Iowa, was the beginning of the most meaningful and supportive informational conversations I'd had. She encouraged me to connect with the Dana-Dwek Foundation. It was my initial conversation with Tom Stanton, Danny's uncle, that changed everything for me. Someone who had the lived experience with SUDEP, who understood and could relate so well to that type of loss. I started to learn more about SUDEP and that providers were aware of it, however, not disclosing. I started to feel empowered with support and knowledge to trust my voice and realize how important that was and how that can help carry Brendan's light and love forward into this world to help others. My advocacy spans 9 years and has been gradual to evolve. It is not always big and bold, but many times more subtle and intimate. Even though I wish the circumstances that have led me to so many amazing people and opportunities were different, I truly believe all of them are a gift from Brendan. It has been wonderful to feel the outreach and connection that this study has created with so many of you, and I truly look forward to connecting further with more of you as we continue this important work. And Allison, if you want to just move through the next slides, these are just some examples of the involvement that I have, the advocacy that I do in the connection. It spans from our local, just in-state with the Epilepsy Foundation. Some of the work I'm most proud of and that means the most to me is being a SUDEP ambassador, connecting with bereaved parents. I've established over the last couple of years a beautiful visual remembrance video slideshow that we display at all of our walks. And it's so meaningful to families across Iowa who have lost loved ones to various types of epilepsy-related deaths. I've been a part of connecting with the University of Iowa research team and SUDEP. Many of you guys know Dr. Richardson or Buchanan from PAMI conferences as coordinators with that. And then the University of Iowa researchers that bring posters often to the conference. I've been a part of Danny Did since 2019, and I've run on 7 of their marathons in Chicago, connecting with people all across the country through that and recruiting people that were near and dear to Brendan to participate as well. I've worked with startup device companies. You'll see a picture there of it if you want to switch to the next slide. On a device startup, giving parental feedback and so forth. I've been able to speak at Danny Did fundraisers, PAMI. I was part of the inaugural device roundtable in Washington, D.C., and then at a local level, just advocating in the legislature for our seizure safe school, which we were able to pass last year. If you go to the last slide. So just leaving you here with this quote here that, the loss is immeasurable, but so is the love left behind. And may that be our North Star and our guiding light as we move forward through this important work. So thank you for letting me be a part of this. Thank you for all the parents that participated and all the researchers that have done the work. And like Itay had said in our email to all the parents, may this be just the beginning of a lot of great things to come for this. Thank you.
Thank you, Jennifer, for your presentation. And this last quote, I think, is really meaningful to all of us. And, we see a lot of those who have responded to your call in the chat to share their loved ones with us. So thank you
Thank you.
for being here and sharing all the work that you've done in the community. I know I've been on a marathon team with you, so she's not kidding when she says she's done a lot of marathons. So, and with that, we'll turn it over to Dr. Itay.
Hi everyone. I'm so happy to be here today and speak about this such an important topic. So in the next few minutes, I'll present the study, and I see the members in the audience. Some of you are aware of it, some of you were participants in it. And I'll go through the main findings and kind of also talk about my personal journey with SUDEP counseling. And before I begin, I'll just say that as a fellow, sitting next to Dr. Pearl, who was my mentor at Boston Children's Hospital, I remember him counseling people about SUDEP when I just began. And I said to myself, I mean, why is he talking about this to these people? Like, it's obviously not going to happen. I mean, these are such simple epilepsy cases, that, I mean, why even speak about it? And then as time went by and I participated in the first PAMI meeting, I understood the seriousness of it. And I tried to listen more to and be attuned to how Dr. Pearl and other physicians in Boston talk about it, and learned that, first of all, not all of them do, but the ones who do have different styles, and all of this I'll come back to it at the end of the webinar today, but I've gone through a major journey in this aspect, and this will be part of the presentation today. So, Alison, next slide, please. Um, there are guidelines that the American Neurology Academy and the American Epilepsy Society let out in 2017 and then revised in 2021. Of guidelines of how to speak about SUDEP in general or when to speak about SUDEP. Expert opinions, as you all know, are unanimously and consistently saying that it's so important to speak about it to every person with epilepsy and their caregiver or family. There have been tens of studies showing that families and people with epilepsy want to know about it, and that in fact it does not cause anxiety and does not put them in an emotional burden and so and so. But still, as we know, it remains widely under discussed. Next slide, Alison. So our goal when approaching this study was to talk with parents. We actually didn't have a lot of hypothesis into where this would take us. I mean, I had my own hypothesis. I thought that the main findings would appear as they did, but I wasn't sure about it, and we came to it in kind of an open-minded way. Next slide, Alison. For recruitment to this study, we were helped by these three organizations, which did a wonderful job in letting people know about the study. Next slide, Alison. Thank you. And as part of this study, we spoke with 51 parents of 43 children who died from SUDEP. And in our conversations, which were semi-structured, and semi-structured mean that we had the questions that we prepared, but we were planned to deviate to wherever the conversation would take us, and that's why it's semi-structured. We didn't have to stick, to abide to them strictly. And we covered 5 big areas. First of all, we talked about the child and his life, his epilepsy journey, how they were taught about epilepsy, how the parents' interaction with the treating physician was, and then the circumstances around the event itself and right after the SUDEP event. Then, of course, the emotional and the response that happened both in the immediate and in long term, how parents coped. And lastly, we asked and probed about the issue of whether they were aware of not. Actually, I don't think I had to ask about it once even because everyone just brought it up even in the first 5 minutes of the conversation that this was the biggest elephant in the room, like that they were either aware of it or not aware of it. And of course, to all of these areas that we covered, We factored in the parents' demographics, for example, were they married, were they employed, where did they live in the United States? Um, we factored other stuff like their child's condition. Was it controlled epilepsy? Was it drug-resistant epilepsy? How many drugs did the child take? How long was his epilepsy until the SUDEP? And we try to see whether these factors change anything in the grief, coping, or anything that had to do with what we talked about. Next slide. Um, the analysis we did to the transcriptions of the interviews were using a method called immersion and crystallization. And you see here Professor Carnielli Miller, she's actually a world-renowned expert in this, and she helped us a lot with this analysis. Simply said, it's a way that we read the transcripts over and over again and again and try to find common patterns, common denominators between what people say, and then organize it into groups that we call themes. And then next slide, Alison. So the themes that came up of this study, there were four major themes, and each theme had a few minor or sub-themes. So the biggest themes that, again, repeated in almost every interview that we had, I think in every, not almost, in every interview, were the immediate, shock and trauma that happened to everyone and was really unanimous. There is no question about it. Some had problems with the police. Some had problems with the treating neurologist. After I'll touch upon this after this slide. And then the second theme was the grief that followed SUDEP and the particular aspects of it with respect to SUDEP, which, we don't want to compare apples and oranges. When a child dies, it's devastating, and it doesn't matter from what the child dies, right? So I don't want to compare different types of death of a child. With that said, we did see a specific pattern here of grief and that's linked to anger and guilt that, is not mentioned in any other type of literature about grief. And I'll also talk about that. Coping was also very specific, and there were several aspects of coping that I will discuss. And of course, everyone, including everyone that I talked with in this study, mentioned the fact that SUDEP should be discussed, had ideas how to discuss SUDEP, and had a lot to say about why it's not discussed. And of course, this will be the main aspect of our study here. So next slide. Regarding the particular results. So with the initial shock and trauma, as I said, everyone talked about it. And there were not really significant differences that were based on whether it was a mother or a father, or whether they were married or not married, or anything like that. Everyone had shock and trauma. With respect to the type of grief, we saw that mothers reported slightly more intense symptoms of complicated grief. And people who were married, it seemed to help them, and they had less intense grief in a way. The people who were not married took it a bit, it was harder for them. And we saw that this was kind of expected, and we saw that, the longer between the SUDEP event and the time of the interview, the less emotionally intense the interview was. So time had obviously an impact here. And when I spoke to people whose child died 6 months ago, it was different conversations than those that, died 12 years ago. Next slide. With respect to coping strategies, again, women, mothers seeked more group therapy or individual, like psychotherapy. Being married, having a spouse, whether it's a biological parent of the child or not, was helpful, and we saw that it was a helpful coping mechanism. And also being employed. Some people left their jobs after SUDEP, and we saw that had a negative impact, and keeping the job or continuing working had a positive impact. And factors that surprised me, at least, that were not associated with any difference whatsoever was the child's age at death. I expected that, the older the child would be, the harder it would be, but it was not like that at all. The type of epilepsy, I expected it to be that, if it's a drug-resistant epilepsy and with someone who is intellectually disabled, I expected it to be easier, but it was not like that at all. Again, the level of seizure control didn't have any impact, nor did the duration of epilepsy before the SUDEP. So people who had epilepsy for a month and then SUDEP happened, or for 20 years, they had the same, grief, coping, same difficulties. Next slide. All right, and this is the main finding of the study. So out of the 51 parents that we spoke with, 27 were unaware of SUDEP and 24 were aware of SUDEP before it happened. Now, this isn't sporadic. This isn't a random number because I had about 200 emails of parents wanting to participate that were unaware. And after a certain point of data saturation, we really had to filter them out. We had to say, sorry, like screen them out. We have enough of people who are unaware. We're looking for those who are aware. So we had to find them, like find a needle in a haystack. It's not like it was very prevalent. But it took time, and they did approach us, and we approached them, and we found 24 of these parents who were aware before. And the main findings between these groups were that the trauma was different. In the aware group, those who knew about SUDEP before, it was somehow mitigated, and I'll show examples later. The symptoms of grief existed, of course. They lost a child, but they were somewhat more, in parentheses, normal, if I can say. It took a normal amount of time, as described in psychiatric literature. There was definitely much less guilt, if not at all. And I'll show examples of that also. There was definitely much less anger. And if there was anger in this group, it was not directed at the medical establishment. It was directed at, why me? Why did it happen in this and this circumstances? But there wasn't the deep-rooted anger that we saw in the unaware group. The aware group relied a lot less on SUDEP support groups because they said whatever happens in these groups is that they talk about why they were unaware and how it's not okay they were unaware, and we were aware, so it's just not relevant for us, and they just didn't really participate in these groups. And so I assume that you see less of them because, people who participate in groups because they just don't come to it. And in general, there was more acceptance and kind of peace of mind in this group. Of course, it was extremely hard for them. Don't take this like it's not an absolute thing, but when we compared them, we saw significant differences. Next slide. This is just a table of the crude demographic and clinical data. I'm not going to go into this. It's just to show that there were no differences between the aware and unaware group with respect to any demographic and any clinical parameter of the child, except I think one, that I think the number of anti-seizure medications was higher in the aware group, but I'm not even paying any attention to it. There was no clinical or demographic differences between these groups. And it's important to show this because if, for example, the aware group were all, parents of children who had drug-resistant epilepsy, this may have an effect, but it didn't. It wasn't like that. All right, next slide. So I just want to give you examples about every, theme that I raised here. So let's take a look at the shock and trauma. A quote from a parent who was unaware, which maybe many of you will think, you could have said it. My husband is having a hard time because that's the way you found her. It's going to haunt me for the rest of my life. That's what the husband said. And an aware parent, yes, knowing about SUDEP softened the blow because the minute I rolled him over, and I'm having goosebumps now when I read it, yeah? I'm like, this is it. It happened. The thing I dreaded is here. And yeah, I think not knowing, you would be like, what the hell is going on? And of course, by the way, the names here are not the real names of the participants. These are pseudonyms. Next slide. With respect to, the immediate period after the SUDEP and whatever happened, the interaction with the police, several or many unaware parents said they had these misunderstandings with, law enforcement personnel, which put them in a separate room, wouldn't allow them to see the child. And it was evident that when the parent is unaware of what's going on and when the law enforcement officer is unaware of what's going on, there are these misunderstandings. If the parent would have known and said, hey, this is something that can happen in epilepsy, we know what happened here. I mean, maybe the policeman would put it into context. But when both don't know, it brings a bigger difficulty. And then a quote of an aware parent, it's a weird thing to say, but it's just a nice interaction with the police officer, which might be random, but also might be because there was some kind of mental preparation for it. Next slide. Um, Talking with a physician afterwards, if the physician had told the parent about the possibility of SUDEP, you know, obviously the conversation afterwards would be different than if you didn't say it, and then the anger would be much higher. So a quote from the unaware, I felt betrayed, and I heard this from so many parents in so many ways. Betrayed is actually a softened word that I put here. There were much harsher words. And then the aware parents, the ones who knew about it, said a lot of things that were kind of nice. The physician talked to me about it, said some like general stuff that, yeah, it could happen. I'm so sorry. And there was just less trauma with this interaction with the physician, less anger. They stayed in touch in many, many of the occasions. Next slide. With respect to the guilt, that's maybe the most drastic difference that we saw here. Um, the parents who knew about it before just had a lot less, if any, guilt. And just this is one of the nicest quotes that I like from the study of the in green here, that the parent who was aware said, the epileptologist mentioning it, it saves my sanity even today. And this is 11 years after SUDEP. It soothed my mind knowing that I was told about it, because I know that there was nothing I can do or have ever done that would prevented it. And maybe this should have been the title of the study, really, because it says everything. I don't even have to explain it. And then with the unaware group, there are so many versions of what's written here. Of people who told me I would have done that. I would have called an Uber and come back home. I wouldn't have ordered the dinner. I wouldn't have done that. I wouldn't have watched my favorite television show knowing that he was upstairs in his room. I would have monitored him. I would have bought the night watch and the special watch that we have to monitor. I would have done all of these things. I would have made him take his medications, put someone to sleep with him. I heard so many of these things, uh, as expected. So that was the starkest difference. Next slide. This is something that's just maybe a nuance, but it's interesting. Several of the parents were religious and really, like really religious. Their belief was absolutely real, and I can spot real religiousness. Um, and when we compared the religious parents in both of these groups, it was interesting that the comments made by those who were aware were like, yeah, God has a plan. It sucks, but it has a plan. So they didn't lose their belief as much. They continued going to church, for example, versus a lot of comments we heard that were like, this makes me angry. This makes me question God. This makes me question faith, and so and so. I think one person also left the church because of it, and like left God, left their beliefs. It was really drastic. Next slide. Um, with respect to the support groups, as I mentioned before, it was interesting that the people who were aware didn't feel they really needed the support groups because, as they said, their words, most of the things they talk about is why weren't they aware and it's not relevant to us. And then the ones who were not aware really find, as one parent told me, it's like I'm a Martian going to Mars. It's like my community. No one can understand the death from SUDEP except these people in the support groups because no one has gone through this situation where you didn't know about something and then it happened and then you found out it could happen and your anger and guilt and everything, it's so specific that it's uncomparable to any other type of death in a way. So that's why they needed the support groups. Next slide. And with respect to the discussion, I think we covered this. So a lot of the parents that were aware before told me how the physician had told them about SUDEP and said, for example, it was very informative, it was even light, it didn't feel jarring, felt like a natural part of the conversation, which is, by the way, like how it should be, and I will speak about it at the end of the webinar. Um, and it just felt like more information that he was arming us with. And that's, again, such an important comment to the study and a message for physicians that it can be like that, and it should be a non-issue to speak about it. Versus hundreds of comments like you see here in blue. I would give everything to go back and have the doctor talk to us about it. I would give my life. Just let us try, as opposed to letting the doctor make the decision for us. Such a strong comment. Next slide. Lastly, and I'll end with this comment, which also kind of resonates with me almost every day. It's one of the parents that kind of summarized everything. And I'm showing this with a title of a manuscript that showed that even children that have, what used to be called benign Rolandic epilepsy, now it's called self-limited epilepsy with central temporal spikes. It's kind of a lighter or milder version of epilepsy that happens near adolescence that we expect to fade away after a few years, and these people don't have epilepsy in the future and don't need medications. Even to them, and actually 4 children in the study had benign Rolandic epilepsy and they died from SUDEP. And so one of the parents said, summarized it and said, epilepsy carries a risk of dying after a seizure, like, there's a risk of an accident after a seizure. And there are certain ways, things you can do to mitigate it. It's really as simple as that. So this is how epilepsy should be presented, like a life-altering diagnosis, period, full stop. The doctor should do his best, to help you be as normal as possible, as opposed to the non-stop reassurance that everything is normal. And, as a personal thing, I can say that sometimes I find myself saying to patients, your child is completely normal. He can live a normal life. Everything is great. And it's true. We really want them to live a normal life. With that, it doesn't mean you don't need to talk about the risks and about the comorbidities. It's just part of it. There's a way to do it. There's a technique to do it. And we'll also speak about this at the end. And then the last, word here, there's nothing effing normal anymore. I heard a lot of the F words were in this study, and this was one of them. Next slide. So to summarize, being unaware of SUDEP leads to complex, far-reaching impact and effects on parents who lost a child from SUDEP. Everything changes, the grief pattern, the coping, and it stems from this perceived feeling. And I emphasize the word perceived here. Whether it's true or not, it doesn't matter. It's perceived. The perceived feeling that death could have been prevented if the parent was aware. And that's the bottom line here. Being aware provides a sense of agency, leads eventually to mitigated symptoms and to a higher chance of inner peace and acceptance of it all. Next slide. We talked about these gaps of SUDEP counseling, how it's important for the physician to also know that after it happens, whether he spoke about it or not, to give the needed empathy, to talk about it, to say sorry about not speaking about it, everything. And how we need to focus on implementing, effective SUDEP counseling models. And I think I spoke to some of you in the past and said that in the last, American Epilepsy Society meeting, there was a session about SUDEP, and a parent actually stood up and said, everyone gets it. We need to speak about SUDEP, but like, what resources do you have for that? And the panel, which were all experts in the field, said, we don't really know that there are resources for that. And this is kind of a teaser to what I'm going to speak at the end of the webinar. But we need to, figure out how to train neurologists and epileptologists to just simply speak about it. It's not such a big deal. And then also, law enforcement agencies, emergency room personnel, medical examiners, everyone in this field has to know more about it. Next slide. And this is, I think, the last slide. And it just shows a snowball effect that happens when medical examiners are less aware of it. It's underreported. Its prevalence is misperceived as low, and then it's undercounseled by physicians. Prevention efforts are then not maximized by parents, and also law enforcement personnel and EMS people are less aware of it. And I know that I'm preaching to the choir here. All of you know these things, and it's it's like stating the obvious to you guys, but still it needs to be said, and it needs to be reminded that, for example, take this article from New Zealand. They looked at the incidence of SUDEP in New Zealand with, they have a better organization of the records of the healthcare system then, because it's a smaller place in the US. And they saw almost triple the incidence than reported in the US of SUDEP. So what does that mean? Maybe we're misperceiving it as low. It's just an example. And next slide. This is part of a bill that I was part of in Massachusetts to promote SUDEP awareness. It wasn't specifically for SUDEP counseling, but for awareness in general. And I'll just say that I'm not sure that these laws will change a lot. I'm really happy that people are doing them, and I was proud to be part of it. I think physicians are more driven from love than from fear, if we can say that, and they need to understand the justification behind counseling SUDEP than be afraid of not doing it, if this makes any sense. But anyways, this was a great experience. And next slide. These are my colleagues that helped in this study and were major contributors. So Professor Carniel Miller, that is with us, and Dr. Phillip Pearl, who will speak after me, Gardner and Ellison, who you all know, and Daniel Friedman from NYU. David Williams from Boston Children's is also a qualitative studies expert. And thanks to all of you for listening for this part.
So thank you, Itay, for covering all of that. And someone asked if your slides will be available, but I can put the published study in the chat since it is open access and people can read it. And we'll give you a little bit of a break before you jump back in and hand it over to Phil.
Okay. Itay, I hope you get to look at the chat comments because they're remarkable. And I'm Dr. Phillip Pearl from Boston Children's Hospital. I'm very, very happy to be here in a sense. Maybe happy is not the right adjective, but I do want to thank Allison and Dr. Jeff Buchholter, who is here on the panel, and Pammy, and also the Mark Chaparrin Foundation, all for your support of advocating for this topic. I want to thank Jennifer, who professionally is a nurse and a bereaved parent. Your story was just heartfelt. And I especially have to thank Dr. Tokatly Latzer because this project was his brainchild. He was inspired to do it, I think, after we presented on SUDEP in the metabolic epilepsies, our area of research, during a PAMI meeting. And here we are today with this article that was released last month in the journal Neurology. It had an accompanying editorial highlighting it, and it's getting more and more prominent. So I'm going to talk to you a little bit about the SUDEP discussion. Next slide. What did we learn, basically, for all that fantastic information you just heard? Interestingly, in our study, and this, as Dr. Tokatly Latzer said, we didn't have any preconceived notions. We went into this kind of blindly. What were we going to find? Well, of about 50 parents, we found that half of them had been unaware of SUDEP, and that emerged as the major touch point. Now, there are many major touch points for mishaps involving SUDEP, right? Involving the emergency responders, official personnel like police, law enforcement, medical providers such as ourselves. And that's not just the epileptologists, but neurologists, primary care, emergency doctors. All of these responses could be improved with prior awareness on the parts of all these people, as you just heard. So what we learned basically is prior awareness is the most important factor to assuage the grief response, because coping is needed ultimately. And the coping process goes a whole lot differently for those who are aware versus unaware, as you just heard. So now let's talk about the SUDEP discussion. Next slide. What about some basic informational items? What is the incidence? At least the estimates are these. The incidence of SUDEP is about 1 in 10,000 newly diagnosed patients and about 1 in 1,000 adults with chronic epilepsy. Not quite as common from most studies. There's a little bit of disagreement that it might be just as common in children, but overall, the pediatric study is about 1 in 4,500 children with epilepsy will have SUDEP. But anybody with medically refractory epilepsy where seizures persist despite medications, the chances start to really go up anywhere between 2 to 10 out of 1,000, which is approaching, 1 out of 100. Most cases of SUDEP occur after a massive generalized tonic-clonic seizure or convulsion. Most that have been witnessed, that's when they occur. There's still a lot of uncertainty because this sudden unexpected death in epilepsy patients is unexplained. And whether it has to do with a seizure discharge that goes straight to the heart and stops the heart, or something mediated in the brainstem that controls autonomics, we don't really understand the pathophysiology or the mechanism of SUDEP, but we sure know that it just about always occurs after a massive seizure. Most cases are unwitnessed, but most cases are usually found prone or on their stomach in bed. Next slide. So what are the major risk factors? Well, it's someone who's having active generalized tonic-clonic seizures, but of course not exclusively, someone living alone, patients who have a history of prolonged periictal apnea or decreased breathing surrounding the seizure, be either during or after, and the presence of nighttime seizures, seizures from sleep. Next slide. There are other risk factors as well. Early age of epilepsy onset, defined as less than 16, having a longer duration of epilepsy, having had it for over 15 years, having concomitant intellectual disability, male gender, lack of anti-seizure drug treatment, elevated body mass index, and alcohol and drug abuse have all been identified as risk factors for SUDEP. Of course, the problem with statistics is they're just probabilities. They're not certainties. And if it happens to you, the statistics sort of get thrown out the door. But this is what's known about the risk factors for SUDEP. Next slide. Now, there are combinations of risk factors that are really important. So if you take the best and worst case, the worst case scenario is that if the patient is living alone, it used to be we would write letters for the kids going off to college. They needed their own private dorm room because the stigma of epilepsy is overwhelming and they didn't want anybody to know. Now we write letters saying this patient has to have a roommate because we know from lots of data that the worst case scenario is someone who lives alone, who is not compliant or adherent or basically taking medication or their prescribed medications, and having generalized tonic-clonic seizures with at least one in the prior year. The risk all of a sudden is 2 out of 100. So it's going to happen. I mean, those of us like myself, I've been in the epilepsy world as a practitioner for 35 years. There are going to be cases in my practice and that I'm aware of and all you are aware of, unfortunately. The best case scenario is a patient who shares a bedroom, has 0 generalized tonic-clonic seizures within the past year, and is adherent to medication, and then the risk drops to 5 out of 100,000. So this is the issue because every family who wasn't aware, no matter how angry they are, their statement always begins with, if only I knew. If only I knew we would have done this, we would have done that, we would have, there's so many things, but it's always if only we knew. Next slide. Now, there are pediatric specific risk factors. The presence of intellectual disability, having a structural brain lesion on an MRI, having an abnormal neurological examination, having an underlying epileptic encephalopathy, having medically resistant epilepsy, and having a genetic epilepsy like Dravet syndrome and many other channelopathies and other genetic epilepsies are definite risk factors. And since our work is in inherited metabolic epilepsies, I'm sure to let our families know. And when it does happen, it's definitely helped their ability to put one foot in front of the other that they knew. Next slide. So there are modifiable risk factors, and here we have to get the word out. Adherence to treatment, avoiding alcohol and drug abuse, avoiding sleep deprivation, having assistance available overnight, treating sleep apnea when that fits. We're not sure about all these monitoring devices, but they certainly make sense, including the lattice pillow that allows for rebreathing, but the role of that's being established. And basically, there are a lot of devices that are coming out so that a patient will be aroused or moved from the prone position, say, onto their side or onto their back to help them breathe in the event of a seizure. That's where we're going with technology. Next slide. So we have a discussion pathway that we try to train our physicians, our fellows, our residents, and that includes including the topic in an early appointment and not waiting and waiting. Inviting others into the room because it helps to have more than just just one or two ears in the room. We give advice like ensuring comfort and time for questions, explore understanding of the diagnosis and the risk issues. Physicians need to inquire sensitively how familiar someone is with this topic and with this term. It's a strange term. It didn't, for a lot of us old timers, this term didn't really exist or wasn't very well known until around maybe 2000 or something like that. So past 25 years, but I went to med school before then, and there are still a lot of physicians out there who've never heard of this, and a lot of people who've never heard of this. We like to ask for someone's interest in whether they want to know more about it and talk about it. And, we have to put everything in context. It's still more dangerous to get in your car and drive home from the doctor's appointment. We're more likely to have an accident than to have SUDEP, and you're going to get in the car and go home, right? So everybody has to learn to couch risk in some kind of palatable format. But we do like to highlight those risk factors that are modifiable. And this is the SUDEP discussion that we need to advocate for as physicians and medical educators as we go and testify, like you heard Itay did at the Massachusetts legislature, and the bill is still in committee, they call it, because I just asked 2 nights ago the status of it, so I have an update for you today, and it's in committee. So the legal process is long and arduous and hard, at least in the US. Next slide. And these are some references. So those are my comments, and we can move on. Thank you so much.
Thank you so much. And that was a good summary about our legal process as well, tossed in there. But yes, we are working on some of those legislative pieces as well. And then we'll go back to Itay, and then we have a few questions that have come in. So back to you.
Right. So just quickly over the next 5 or 6 minutes, doing this study gave me and my colleagues a lot of motivation to continue and do something active, to change the way that SUDEP is not counseled. And I bring you back to the comment of that parent in the discussion in the AES that said, what resources do you have for SUDEP counseling? So there aren't really any. And we decided to create one for that reason. And we're working now on creating a counseling AI simulator. Now, obviously, in an ideal world, every pediatric neurologist, adult neurologist, epileptologist would have a line of actors to sit with and practice how to talk about SUDEP with real life actors. But that's not realistic because there aren't so many actors in the world that are available on a daily basis for that. And it's expensive and, it's a logistic nightmare. And we can overcome that, although it's not like a human being, but it is almost like a human being. And it simulates a person that, in this case, this is a mother whose daughter just diagnosed with epilepsy. And you're the physician, and you're supposed to talk about SUDEP with her, talk about epilepsy and SUDEP. Of course, you can't just drop SUDEP. You have to talk about epilepsy before and put it into context. Now, it's not just, that we do this simulator and expect physicians to just talk about SUDEP. We also provide them with an approach, which Professor Carniele Miller developed, and I'll show you this approach. And it's based on a method of how to deliver bad news, how to talk about, these things that need extra risk, and how to, approach this topic and make it as with less alarmism as possible, and in the most constructive and helpful way that will leave parents, with the information that they deserve to have, as simply as that. So next slide. And I actually spoke about all of these things already, so I don't need to repeat it. It's the objective of why we're doing the simulator. And of course, after we're doing it, I'll show you this, the physician that just did the training gets a very elaborate feedback on the way that he spoke, gives them pointers of what to do better. They can train, maybe many times in order to master the skill. And I can tell you, as someone who has been in this journey and done this simulator already like more than 5 times, the learning trajectory is so great, and I'm seeing how it affects me on a daily basis in my clinic. Even today, I spoke about SUDEP with 2 new epilepsy diagnoses, and it's become so simple and so good, and parents thank me afterwards. And I mean, you need to know how to do it. It's not just doing it. And I'll show you how. Next slide. So, okay, the long-term goals of this simulator, I didn't mention this, is to make this available for, hopefully every trainee that does pediatric neurology, adult neurology, and epilepsy in the US, maybe abroad. And, make this a platform that just physicians can use to train themselves on this topic that, creates a lot of, there's under-counseled, as you saw. Next. So this is how it's built, the simulator. Participants do the simulator, and then they undergo this debriefing afterwards of how they felt with the simulation, and they're given structured feedback according to this SPWICES. You see this acronym SPWICES, and I'll show you what it means. It's an acronym that symbolizes the method of how to deliver this any bad news, but we tailored it to SUDEP. And next slide, please. So when the simulation starts, the physician gets the case. I'm not going to read everything here, but it's a typical case of a 12-year-old girl that has, benign Rolandic epilepsy, and she had a generalized tonic-clonic seizure. Next. And then this is just an example of how a simulation conversation would look like. So this in case I did it, and I called myself Dr. Brandon Welch. I don't know why, but that's how I called myself. And then, the conversation goes on. And in this specific scenario, I didn't want to, I wanted to see what happens if I don't mention SUDEP, because whatever reason. And I wanted to see how the AI bot would respond to it. So next slide, please. And then it makes, generates the feedback. Next slide, please. And, there's this AI person or AI figure that says, hey, tell me about your experiences. I noticed that you didn't mention SUDEP. Why didn't you do it? Next slide, please. And it, gives me kind of pointers on my overall performance and talks about the fact that, what I did well and what I can improve.
Did he freeze for you guys too?
Yeah, why don't you go to the next slide?
Yeah, you can go. This is the SPWICE's protocol of setting and then creating the best setting that you can have, perception of really understanding what the person knows. Because, for example, the mother is new to epilepsy. So there's a need to explain a little bit more for her and then move forward to other patients. Warning call is every time you give some difficult news, then you have to help a little bit by gradually explaining what's going on and what you can be concerned of. And then it's about providing information in a manner that is clear, but it's also very empathic and answering questions and helping them getting through. This is the structured feedback. It's part of the structured feedback, so it actually includes parts related to each of the SPWICES protocol. Itay, you're back.
Yeah, I'm sorry. I don't know what happens, but thanks for covering and showing this. So indeed, the detailed feedback covers every part of this acronym that I showed you, the SPWICES, and Allison, you can go to the next slide. And these are every letter, what it means, warning call, information, clarification, empathy. The next slide. And that's what happens in the end. So it's still in preliminary stages. We've sent it out only to a few neurologists to try. We're getting feedback from them, and we're fixing it every day as we speak. And we have hopes for it. And this is one thing that can be done. There are many more things that can be done to, encourage more SUDEP counseling. And again, just sharing my personal journey that I went through and how from, sitting in front of patients and swallowing my tongue every time I have to speak about it and making it look awkward to, just having it almost as a non-issue today and speaking about it. I speak about it with everyone, including the first time the epilepsy is diagnosed, and I've seen that what I've went through, and I think any physician can be in the same mindset. So thanks again for all of you for your comments and for participating. And Alison, now we're doing the questions.
Yeah, we're just a little over time, but I do want
Okay.
to ask the one question that came in if people want to hang with us for a little bit. And maybe Jennifer, you might have insights on this as well. But Wendy was asking from the research that was done, was there any indication in the parental comments about the effect on siblings? So they had experienced a loss of a loved one, and they also have another child with epilepsy. So they're just curious if that sibling effect came up in any of the research.
Yeah, it definitely did. It came up almost every time when there were siblings. It had a drastic effect on sibling in many difficult ways. It's almost a topic for another study. There was so much data on it, and there was a limit. There was like a limit of the scope of the study that we could include, and we couldn't speak about everything, but it was definitely an area that was needed special attention and was difficult for many people. Yeah.
I'm just going to add that remember, we talk about the vulnerable child syndrome. That defines the sibling of a child with a chronic disease or a child who underwent some severe medical crisis. The siblings considered the vulnerable child because they're often by necessity ignored or deprioritized or whatever the reality dictates. So you have to think about that sibling as vulnerable and they may need additional support. On the other hand, I've seen so many examples of siblings who are so promising and end up accomplishing great things and going to medical school and becoming neurologists and epileptologists because of having had a sibling or having a sibling with an underlying neurodevelopmental disorder, including epilepsy, including having gone through SUDEP. So sometimes the siblings are the most promising of all.
I think too, and there's a comment in here by Tiffany. I think there were some comments on some of the when the study was shared on social media of how some people who are living with epilepsy or have children living with epilepsy, how can you study their fears and anxiety, that this is a potential to occur. We've talked to parents who have lost, but kind of expanding that study. More siblings can be a separate one, but also those who have living children with epilepsy and the fears and anxiety that they carry surrounding SUDEP because they know about it. So I think that would be an interesting topic as well.
So more research to be done, as we can hear.
Yeah, I mean, I spoke with a few parents who have, other living children with epilepsy, and I think many of them said similar things to what Dr. Pearl just said a few minutes ago, that, also driving home from school or from work carries a risk. And that's how they perceive it nowadays, knowing about it. So the knowing about the possibility of SUDEP doesn't really make them, anxious or anything like that. It just makes them aware of it, just follow the medication regimen and do whatever you can do and what's in your control, like when driving, right? Some things are not in our hands. So, yeah, we had these conversations as well.
Yeah. Well, I was going to say, like Phil said, if you didn't get to read the chat, Itay, there's wonderful comments in there, a lot of appreciation. And Tiffany is sharing about, she's experienced the loss and she's turning that into action. Like Jennifer has shared doing seizure first aid trainings at her school and things like that. So, a lot of, just gratitude for the research being done. And I know just looking at the attendees. I think a lot of the individuals that you know as well from the research. So, I want to pull up one more slide and be respectful of everyone's time here. But as this was brought up a few times, our annual PAMI conference. So I just wanted to share our 2026 PAMI conference information. We'll be in Denver, Colorado, which I know can be kind of cold in December, but December 2nd and December 3rd this year before the AES conference. And December 2nd is our family day, where we have, bereaved families and individuals and advocacy groups come together before the scientific conference on Thursday to, really build community and connection, talk about grief and, allow networking time for those individuals. So we have that. If you have any questions, you can feel free to reach out to me about that. We're just starting to put the agenda together, but it's a great opportunity to meet others. I know many on the call have participated, and we'll be sharing more information as, the agenda and different things come along. But I would just like to thank everyone for joining us today. We had a great showing. We had over 100 people register and over half attended, and we'll be getting the recording out to folks. So thank you all for your presentations, for Itay, Jennifer, and Phil for being here. And when Itay lost connection, jumping in as a team. So thank you all. And anything from our panelists before we leave today?
No, thank you. Thank you, all of you. Again, I'm proud to be part of this community. I hope this community would never have existed, yeah, but I'm proud to be part of it, and everyone is doing amazing job in this advocacy work.
Yeah. Well, thank you, everyone. It's my honor to be able to host this, and we'll keep you posted about the next webinars. And have a good rest of your day, everyone. Thanks for joining us.